Well, those guys are going to pass the microphone back and forth, but believe me, they don't have any trouble talking. So we're going to start out today, and I wanted to introduce, you met Dr. DePetti yesterday, wanted to introduce Dr. Jan Basil, who is a professor of medicine at the Medical University of South Carolina and a volunteer at the VA, where he does research. So,
well, I'm retired from the VA.
Oh, okay, retired from the VA. Alrighty, so today, you heard yesterday Dr. DePetti's really nice discussion of evidence-based medicine. But I have to tell you that the American Diabetes Association and the ACE, which is the American Association of Clinical Endocrinologists, really doesn't agree with the risk calculator. As Dr. DePetti discussed yesterday, we all know that everybody who has cardiovascular disease ought to be on, oh yes, there they are, welcome pills. Everybody who has coronary artery disease or has cardiovascular disease needs to be on a statin. Everybody agrees about that. It's the primary prevention people that we all disagree about. And
And that is why, Dr. Piziak, we focused on primary prevention and the controversy.
Yes, we did. And I loved your slide that said when you're in the exam room, you and the patient get to decide what happens. It's not necessarily the evidence. And in fact, the evidence is not there for a lot of my patients, and it is not there for a lot of your patients, I'm sure. So this is the first lady we're going to talk about, and she does have some evidence. This is a lady, it says, should she be on a statin? She's a 40-year-old female. It would be helpful if you could look. Yeah, then you'll see what we're doing. Okay. I can't help it. I've known these guys forever, and they're really argumentative, so I'm hoping you're going to chime in. Right. A 40-year-old female with type 1 diabetes for 10 years. Okay, 10 years, very important because by 10 years, statistically, you probably have some complications. So you're going to have to watch it a little more carefully. By 10 years of type 1 diabetes and age 40, you may actually have some cardiovascular disease. This is not like type 2. The ADA is upset because all diabetics were lumped into one class. And type 1 diabetes, as you know, is very different from type 2. The cardiovascular risk in type 1 is lower, and it is primarily, at least in the beginning, secondary to an absence of lipoprotein lipase. You give these people insulin, their dyslipidemia corrects. But as you go on, and they have been out of control a bit, then there may be a problem. Okay, so this lady has an A1C of 7.2. That's the average A1C of the people in the diabetes control complication trial who were in the well-controlled group. So this lady is a well-controlled person. She follows an excellent food plan. She exercises 30 minutes 5 times a week. And what's your lipid panel here? Total cholesterol 186, triglycerides 106, HDL 68, characteristic of type 1 high HDL, and LDL is 97. Uh-oh, she falls into that category. We'd put her on a statin, wouldn't we? Okay. She has no family history, no tobacco, no albuminuria. Well, there is limited data about this lady. And if she had known cardiovascular disease, high-dose statin, no problem. But she has no cardiovascular disease. If she had risk factors, we'd put her on a moderate dose statin. Otherwise, no statin. And the ADA says, we just don't like the calculator. They were more diplomatic, but they don't use it. And so neither do most endocrinologists. The LDL is now a risk factor. So they say you don't have to keep repeating an annual cardiovascular. Can I ask a question to you guys? So how come I keep getting from insurance companies a little note that says Mrs. Jones has diabetes and hasn't had her LDL this year? I have to supply an LDL. There's a conundrum. I mean, when are the insurance companies going to catch up? Have you noticed that? Right.
That's above my pay grade, Dr. Piziak. I can't even get faculty to do what I wanted them to do.
I'm writing a note on that saying, Mrs. Jones had an LDL last year. ADA says she doesn't need one anymore.
Question, Joan?
And if you work for like a federally qualified health center, your grades in terms of your grants and that sort of thing are dependent on reporting what percentage of people have gotten those annual lipid.
Why don't you come up and sit with us?
Did everybody hear that? Dr. Lindgren's talking about an HQ, FQ, HC. Yeah.
Right. And you could, if you got your cases, you can come. Okay, because we thought we'd look at a women's health perspective here. Okay, so the LDL is now a risk factor, as is many of the classic ones that you know about, but the ADA says the reason the calculator doesn't work for us is that they don't include things like overweight, family history of early CVD, and albuminuria. And albuminuria is not a risk factor, as you know, but it correlates about 75 to 80% correlation with cardiovascular disease. If your patient with diabetes has albuminuria, the likelihood of their having cardiovascular disease is high. So they're saying that it's not that we don't agree with everything. We find that in primary prevention, we have a different set of risk factors. So the risk factor isn't going to calculate for us. And this lady would not be on a statin. Okay. So the AHA says that she would, basically, and I think you heard about that yesterday. Her 10-year risk is equal to 7.5%. No, actually, it's probably a little less, but she's on a moderate dose statin then. Okay.
But her risk calculation
is less than 7.5.
It's extremely low.
Right. But she swept into that 40 to 75, so we're going to put her on a moderate dose.
Yeah, because of the diabetes. Dr. Basil, even though she's type 1. Any comments on that?
Yes.
Because what Ron is making a good point. Type 1 versus type 2 are all lumped together in the AHA-ACC guidelines. Is there a difference?
Well, yes. I mean, even in that, so you have the 4 categories, which you talked about yesterday. Okay, so the 3rd and the 4th category, one is including type 1 or type 2 diabetes, 40 to 75 years of age, with an LDL of 70 to 189. And the other one is the non-diabetic, non-atherosclerotic disease. But both of them involve a risk calculator. And in both of them, all diabetics are not lumped the same. So we're splitting the diabetics because all diabetics are not created equal. So even in the ACC AHA at age 40 with a risk of 0.75, heavily dependent, the risk calculator, on age, you would inform her and say, she doesn't qualify. No, she doesn't. She still has to have, as a diabetic, a 7.5%. Not all diabetics in the ACC AHA go on a statin necessarily.
Oh, I thought she was on a moderate dose.
Yes.
You calculate by total, not by LDL.
No, you calculate it right. It's not by that. It's by the 7 parameters.
The intensity, Jim,
That's it.
of the
Yeah.
statin.
Oh, here we have the alignment.
If you are 5 to 7.4%, you are a moderate. If you're 7.5% or greater, you're high. If you're less than 5, informed decision, and we are all different. You might persuade the patient at age 40 to go on a statin. I would not say you're wrong. I might not. I might say, you're 40. Ronnie says appropriately, 10 years, you've already had it. We think we're good at when we pick up type 1 diabetes. Type 2, we know that they've had it for several years before we pick it up. But one might give this patient a statin at age 40. One might otherwise say, I'm going to wait till you're 45 or 50 when your risk is higher, because I don't think you need to be paying for a statin for these first 10 years. It's a debatable point. At what age do you really capture the greatest reduction in risk? So I just throw that out.
Thank you. That's a very good throw out. So at any rate, I think that we need to think about that, and certainly your slide, Don, points that out, that we all get to think.
Can I just add to this? What happens when, before all these new guidelines came out, what do you do with the patients who are already on statins? Do you take them off the statins and put them through this risk calculator? I mean, what do you do with these people that are already on statins and we've assumed that they have risk previous to these new guidelines?
Okay, so just like in the blood pressure guidelines, if Mr. Jones's blood pressure is 126 over 86, and he's tolerating his 3 antihypertensives, and he feels well, and he has no problem with the cost of these 3 meds, as it states in the guideline, the clinician may continue the medicines or may decide with the patient that perhaps you only need 2 medicines and you can back off on the blood pressure reduction because the goal is still 130 to 139 over 80 to 89. And with patients like diabetics on an average of 7 to 11 medicines, depending on the severity, the A1C, the blood pressure, the blah, 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 it can be expensive. So you once again discuss with the patient your strategy. My feeling is patients come to us because of who we are. Now, I realize that I don't want to get into the politics of medicine, but I still believe that in the local community, patients come to you because of who you are in the local community. And you have a relationship with them. And it's based on trust and respect. And I think I often tell patients, although my colleagues might do it differently, and when you are in a social circle and you hear your neighbors saying, but my doctor does, tell them, my doctor and I discuss this, it's controversial, but he or she thinks that this is the best strategy for me. So that you put it out on the table that there's no absolute, there are differences of opinion. We'd like there only to be an algorithm and everybody does the same thing. It just ain't so.
And why don't you weigh in from a women's health perspective? You know, my thought on this lady was I'd take her off the statin if she was on a statin, because look at her, she's 40, she's probably going to think about having a baby. Statins are a problem. You have to remember you can't use them in pregnancy. So weigh in on that. What do you think on this lady?
I agree. I wouldn't have put her on it. A lot of times what I'm doing is calling internal medicine and saying, I'm getting the letter from the insurance company, but do you really think this person needs to be on the statin? And usually she'll go, no.
That's a good thought. No. Okay, moving on. And this is the should she be on a statin too. It's the reverse side of this. 30-year-old female, type 2 diabetes for 10 years. All right, she has probably some cardiovascular disease. I mean, statistically, looking at UK PDS and their entry people, if you'd had type 2 diabetes for 10 years, you probably have coronary artery disease. She follows an excellent food plan. She's the same as her other patient. Lipid panel, very similar here, isn't it? Look at that. She has a family history. No tobacco, no albuminuria. Very important in these people to screen for albuminuria. So she's on a moderate dose statin. According to the ADA, she has a risk factor. We didn't use the calculator. We just said, there you go, folks. This lady has a risk factor. If she'd had 2 or 3 risk factors, it's up to us. We could put her on a high dose statin. So she's younger. But I've had people with type 2 diabetes at age 20 who had heart attacks. So I think that we just need to learn that they're different folks. So this is the last one that I'm hoping is going to generate a lot of controversy here. This is a 73-year-old lady with no chronic diseases, a blood pressure of 140/70. But as Dr. DePetti told us yesterday, that's probably because she's alive, that she has mild systolic hypertension. Excellent food plan, exercises an hour a day, LDL is 100, and her risk calculator, I maybe did that wrong, but 15% because she's older. Now, is this lady any worse than she was at 60? Probably not. But she's accumulating crud in her coronaries, Dr. Basil's going to say. So he's going to say, let's put her on a statin. Excuse me, you have said she has a 15% risk in the next 10 years of having a cardiovascular event.
Right, Ronnie.
But if you put her on a statin, it has side effects. You've given her about a 7 to 15% risk of developing diabetes, to say nothing of her cognitive decline, which probably is already starting. And in addition to that, she'll get achy. I don't know what the percentage of achy is, Jim. What is the percentage of people that have significant muscle problems, weakness, achiness?
Very, very controversial.
Yeah.
Well, no. I think it's important to say that it's not reasonably clear-cut, but I totally understand why Don wants to do it, and I would totally understand why all of you would do it. But I think the conversation with this lady is, this is a controversial area in medicine, but I'm committed to you going on a statin. By the way, just for the age of this woman, the recommendations are that you do start with a moderate, because older people are less tolerant of high intensity. So we really don't have the best evidence for high intensity in her. We just want her LDL reduced. And so either way. But I think it's important to tell them this is an unresolved area in clinical medicine. And this lets her know and lets her community know that this is why my clinician did it, and I understand that just in case your clinician did it differently.
Weigh in here.
Jan, no question, but that was an excellent thought. Joan?
What do you want for LDL reduced too, since we're no longer following any?
Mm-hmm. It depends on which. If you're going to use moderate, you want it reduced 30%, and if you're going to use high dose or high intensity statin, Joan, you're going to want it reduced 50% of baseline.
Yeah, so let me throw out another thing which is very interesting in this. So the moderate intensity statins are 30 to 49% from the clinical trials, and the high intensity, which are only a couple, which is atorvastatin 80 and rosuvastatin 20. Now the guideline says 20 to 40 and 40 to 80, but really we do have a clinical trial showing in the acute coronary syndrome and in the stable coronary syndrome 80 does a lot more than 10. But 10 is still pretty good. In the hypertension trial, the ASCOT BP, blood pressure lowering arm, 10 compared to placebo. In hypertensives with two other risk factors, 55 years of age and older, 10 milligrams of atorvastatin in those hypertensives really improve their outcomes. So either one of those. But here's the kicker. Do you even need to check the LDL after you put them on 10 or 80? There's no guideline for that. And what are you going to do? Gosh forbid the insurance company comes back and says, we're not paying for that LDL.
Yeah, okay, fine. I know.
Now, I don't know if they're there yet, but they could come back and say that. The answer is, why do you need a test if it's not going to change what you do? Or is it going to change what you do? And how do you petition these insurance companies who happen to love these new guidelines because they involve less testing?
And how low, at what LDL would you not do this? I mean, if it was 90, would we still do it? If
Okay,
it was 80,
so
would we still do it?
So risk is not predicated on the LDL. Risk is predicated on the initial and the amount of reduction. And in all groups, the same statin reduced the coronary risk the same amount. Now, the NNT is different. The higher the LDL, the more generous or favorable the NNT. But it's interesting. In lipids, we have no floor. Let me repeat that. We really have no floor. There's no evidence that lower is not better, but lower has never been looked at in a double-blind randomized trial where we take this side of the room and put you on an LDL of 10, an LDL 40, LDL 70, LDL 100. Instead, we randomize by doses of statins or statin versus placebo. So as opposed to blood pressure, where we know that lower is harmful, with lipid reduction, we really have no evidence that lower is harmful. However, the guideline says the LDL floor should be no less than 40, but actually there's no evidence that less than 40 is dangerous. But that's what they say. The LDL less than 40, that's where you should stop. Okay, so that's where you are. So if the LDL was 100, the LDL was 80, the LDL was 60, if the risk of the patient from comorbidities is high enough, in 73-year-olds, a moderate or high intensity could be decided upon.
Go.
I have some patients that, the initial levels are like 200 total and 150 LDLs, and you put them just on a small dose of Crestor, atorvastatin 20, and they go down to total 100 and LDL 32. Do you cut back the dosage or do you leave them alone?
I would leave them alone, again, because what Dr. Basil just said is that we're not titrating to a level of LDL. We're titrating to intensity of statin based on the doses that were used in the evidence-based medicine, those studies that we cursorily reviewed yesterday. So you actually could even make the argument to increase the intensity depending on what category that individual fell into, even if they're doing well on the low dose or the moderate intensity statin. But that's an individual patient, in terms of the demographics and the risk factors and the comorbidities of that patient. But I don't think I would reduce the statin based on the LDL going down. But Jen, you may have a different opinion.
No, I don't have a different opinion on that. But I will tell you that the guideline ACC-AHA 2013 came out actually in 2014, early 2014. Actually says that after you put the patient on a statin, you may check the LDL again to make sure the patient's adherent to the medication. That's a good thing because I don't want to confuse you anymore, but there is a variability of response of 100 people in your practice to the same dose of statin. There are some few on a bell-shaped curve that are hyper responders. There are most that are normal responders, And there are some that are hypo-responders. And this is in the journal Atherosclerosis, and it's well known in the lipid community and in the NLA, National Lipid Association. So they allow you to check it for response and for adherence, okay, not for what the level is, but that they're taking their medicine. Your patient may have been a hyper-responder. And I agree with Dawn. I don't think you necessarily have to reduce the dose. There's no difference in the price of the dose. We have no evidence that an LDL of 32 is harmful. When we're born, our LDLs are 25, and then we live a westernized diet, and they go to what they are with everything else that we do, sedentary, couch potatoes, remote control, blah, blah, blah. So, yeah, these are controversies, you know.
Okay, and so the last part of this question is, okay, this lady says, I'm not going to do this when I'm 73. I'm going to diddle around for 2 years and come back to your office. And now I'm 75, and there's no evidence, and now what do you do with me? So I know there's an obvious answer to this, but, you know, we're all sitting here with no guidelines. And so, guideline folks, tell us.
I think you had the evidence because you have that record. If you didn't have that evidence and that record, yes, then that's a different discussion, Ronnie. But again, that's where, and again, and I've heard Jan say this, and I said this yesterday, lack of evidence doesn't mean lack of efficacy. And again, that's why that discussion, regardless of the age of the patient, et cetera, if they were 78 or 80, it's still an individual discussion with that patient.
And the ADA
you in the
agrees
exam,
with you.
in the quiet room of an exam room.
Right. The ADA agrees with you. They say that there's not much evidence over 75, but we know that in the vast majority of diabetics, the statin, regardless of the LDL, lowers the heart attack risk by about 50% and the stroke risk by about 30%. So regardless of age, if these people are tolerant of the dose you choose, fine. So anything else, gentlemen? I know there's something else.
No, I just agree with what you said, and I think that diabetics, in every study that has been done, they are a higher risk group, and they really benefit from statins versus placebo. They benefit from high potency, from more than low potency statins. And I think you have to have a reason not to use a statin in a diabetic, but there may be reasons not to use them. And you know, I teach, when I talk to the medical students, and this may be a fair analogy, there are some physicians, clinicians, that will use a drug the day it comes out. There are some that will use it in 3 to 6 months to see how it fares in the waters, and some will wait even a little longer. And all of us have different strategies and philosophies in how we approach these kind of issues, and I think we're all right. It's just a matter of what we believe is best for the patient.
Okay, so is this yours or mine, Don?
I think that one's going to be yours.
Oh, okay. You've had too many of mine. Okay, this is yours.
All right, you change seats with me, Dr. Pisiak.
Okay.
All right, switching gears. A 32-year-old African-American female. She recently married, and now she's planning her family. So she, obviously now she's made that decision with her family members, and there's a huge incentive now, and they're ready to go to have children. She has a strong family history of hypertension and diabetes. She has a history of stage 1 hypertension for the last 6 years that's been well controlled. And her therapies, presently she's on lisinopril 40 milligrams and hydrochlorothiazide 25 milligrams, and she's still right now on oral birth control. But she now presents to you in the office with the question is, it's time. My biologic clock, both my spouse and myself, is ticking, and we're ready to go. Thoughts?
Calculator says you can't use it.
What? Use what?
You can't use a calculator because
Says she's 32.
Right.
Oh,
Well, that's for a statin.
Oh, yeah, I wasn't thinking of
No.
that yet.
Yeah, you got to get rid of her A's.
Yeah.
Get rid of her ACE inhibitor.
Jan, why?
Oh,
That was a resounding get rid of the ACE
I totally
inhibitor.
agree with that.
Its
Let me
effects.
just say that when this woman first came to you, African-American female,
Right.
hypertension.
Yep. About 6 years.
Right, so I think the drugs are appropriate. I think the first choice I'd make, if she has normal renal function and no clinical proteinuria,
And she did not.
and she did not, the first two drugs I would choose from would either be a thiazide-like diuretic or amlodipine or a pine, a calcium channel blocker. You could use DILT. I'm not going to talk about this much later in hypertension, but most of you underdose DILT. It's like there's a fire in the house and you have a straw trying to put out the fire. So you use 180, 240, maybe 300 of DILT. DILT should be used at 360, 480, and 540. Okay. If not, use a pine. And I love amlodipine. That would have been a first choice, or a thiazide-like diuretic. But for the second drug, even though you could have used both amlodipine and a diuretic for the first two, you picked an ACE or a RAS blocker. Very reasonable. They work well together. Great first two choices. Now she comes in and says, Dr. Basil, I want to get pregnant. Okay. She is stopping her birth control, and you've got to get her off the ACE inhibitor. We used to think you had a trimester to play with it, but we have some evidence, although it's observational, that suggests that even in the first trimester there can be embryogenesis and organogenesis teratogenicity. So we stopped the lisinoprel. There's nothing that sexy about lisinoprel in this woman, and I would probably put her on another drug. And I tell you, I'd put her on amlodipine. I would put her on amlodipine and the thiazide. Now, what else can you use? You can't use a RAS, ACE, or an ARB. Could you put her on a beta blocker? Yes, but African Americans don't do well on a beta blocker. She has no compelling reason for a beta blocker. In fact, beta blockers now are a fourth-line drug and not one of the first three unless she's post-MI or has HFrEF, heart failure with reduced EF. So she would do great on amlodipine or nifedipine or whatever pine, or DILT. I wouldn't put her on verapamil. She doesn't need rate reduction, and at 480 she's going to have constipation. She's got more problems than you began with. So that's what I would do, and we would see what her blood pressure is. But you definitely should not use the ACE or the ARB. The other choice is, what could you use? I wouldn't use an alpha blocker in her. Aldomet, right? Aldomet can be used next door. You know, they're going to swear by it. They love hydralazine because it's POIVIM. Hydralazine is not a very good drug, except when there's a hypertensive emergency in pregnancy. It causes reflex tachycardia, pseudotolerance. It's just, I wouldn't like it. And I wouldn't, you know, say, so there are some other things I could think about, but amlodipine and a thiazide's great so far.
I didn't hear any mention about the hydrochlorothiazide. I heard resounding, get off the ACE and the renin-angiotensin blocker, whether it would have been, in this case it was an ACE inhibitor, but it could just as well have been an ARB.
Yeah, sure.
But I didn't hear anything about I didn't hear any moans or groans about the diuretic.
Oh, I have no moans or groans about a diuretic in pregnancy. No, I'm okay with that.
Dr. Piesiak?
Well,
when I was growing up, I was told about volume. You know,
you want to maintain
you
your
get
volume.
You need that volume expansion in the second trimester, and maybe these diuretics aren't a good idea.
But they work, and you guys are using diuretics, right? Yeah, and but I would have used the lisinopril first. I mean, I have to tell you, Jan, we've had this discussion before, but the ADA still says if you have hypertension, we like you on an ACE or an ARB.
But she only has a strong family history
Right,
of
she does
diabetes.
not have
I'm
diabetes.
sorry, she doesn't have diabetes. I'm sorry.
Can I comment on that?
You can comment on that, but the ADA still says must.
Jen, we're going to let you comment on everything.
Okay, so real quickly, there is no evidence for a RAS blocker, even if she's a type 2 diabetic without CKD. The ADA can say what they want, and I have no problem with you using an ACE or an ARB first. But I will tell you, in the all-hat trial, blacks like this woman, who were first put on lisinoprel in the all-hat trial compared to chlorthalidone, had a 40% increased risk of stroke because it just doesn't reduce their blood pressure like the thiazide. So if the renal function is normal, there is no compelling reason to use an ACE or an ARB first in a type 2 diabetic, but everyone does what Ronnie does. Now, as a second drug, I would have added it. And as a first drug, if you want to use it first, go ahead. But I'm telling you, in a black hypertensive, you're not going to get the blood pressure reduction that you would have with a thiazide or a CCB. If you backfill after you use the ACE or the ARB first, fine. Add the diuretic or the CCB. But it's delusional. I'm very strong on my feeling here because the evidence is against what the ADA is saying here. Now, if they have clinical proteinuria or a GFR that's low, right, stage 3A, certainly stage 3B, I understand why you're doing that. But not in all diabetics just because they're a diabetic. 15,000 diabetics in all hat. They did worse on lisinopril than chlorthalidone when they were African American.
And again, Jen, what you're talking about is as single agents. Because once you're on the combination, all things are equal. Yeah. As long as the blood pressure goes down.
Don't let an insurance company zing you for starting a diuretic or a CCB in a black hypertensive who's a type 2 diabetic with normal renal function and no clinical proteinuria.
No problem there. Just start the lisinopril and the diuretic at the same time.
You could do that.
Which is what most of us do, because the lisinopril is not a good blood pressure lowering medicine.
Most of us do exactly what Ronnie is saying. She's in the norm here. She's going to use an ACE or an ARB in a type 2 diabetic regardless of their renal function. She's doing what the party line says to do.
But you got to look, and maybe it's not going to work. And instead of continuing to raise the dose of lisinopril, you need to add something. And generally speaking, although I generally don't agree with you about anything, a thiazide diuretic would be fine.
I just might make a pitch that clearly, if you want to start the two drugs together, an ACE and a thiazide is an absolutely fine combination. But also consider an ACE and a CCB. An ACE and a CCB like amlodipine combination, because there is at least one trial, the accomplished trial, which showed that combination was superior to an ACE and a diuretic, but one trial doesn't evidence-based make. Okay. I thought this was going to be a very benign, very easy case.
And we're about at the
plot thickens.
The plot thickens.
Yeah, it gets worse. No, it doesn't. Actually, she does quite well. All right, BMI. We'll continue on, and there you go. BMI is 27. Rest of physical exam is remarkable. There's her blood pressure, and as I told you, everything else is fine. And she had pre-diabetes. Any difference?
Nah.
Because of that one factor.
What's she on now?
She's still on those two drugs.
Lisinopril
and diuretic. We haven't even made a decision yet on the. Does that make a difference? I said she wasn't diabetic, but her A1C is 5.7.
Essentially, she is.
No?
But I think your choice, his choice, was fine. You know, amlodipine's a really nice drug, and I use it in pregnant people. Hopefully that isn't a disaster.
That's fair.
Yeah.
Well,
she has to have a
Dr.
diuretic.
Lindgren, are you looking at these slides?
I just, and absolutely they do.
That's because she's pregnant.
Well, but we're not going to say that. We're going to say we're going to leave her on her diuretic and use amlodipine, and that's what I generally do with these people, is to use a CCB.
So I love 10 of AMLO. I love 5. I love 2.5. If you can't use 10, go to 5. If you can't use 5, use 2.5. A little AMLO is better than none. If you use an ACE or an ARB with AMLO, you're going to reduce the edema. Okay? You're not going to use a loop diuretic for that edema. That's capillary venodilatation. You have to cause venodilatation and arterial dilatation to reabsorb that fluid. So it's not a volume excess. It's just the fluid weeping into the interstitium that's gravity dependent in the legs. And it's much more sensitive for women who like open-toe shoes, the Imelda Marcos syndrome, than it is for men. In all the clinical trials we've done with amlodipine, which, by the way, is the second most evidence-based antihypertensive, just secondary to chlorthalidone. And amlodipine is just a great drug. Very excellent for stroke reduction. If you're coronary prone or have a history of angina in a number of trials, very good in the heart patient. Not good as a first drug if you have chronic kidney disease, but with an ACE or an ARB, autoregulation occurs, afferent arteriole dilatation is balanced by unloading the efferent arteriole, and it's a nice interplay in the kidney now. So amlodipine's a hell of a drug. If you're going to Haiti, you're a missionary, you guys are going on these trips, if you only have one drug you can give, it's going to be amlodipine. Almost in the water, Don, and I'll tell you why. Amlodipine does nothing to your metabolic function. You do not have to check any electrolytes. Amlodipine does nothing to your renal function. You don't have to check that. The only thing it does is cause edema, and the patient will present to you with a complaint. So if the FDA ever was going to allow any drug to be over-the-counter as an antihypertensive, they probably would pick 2.5 of amlodipine.
All right, for sake of time, what happened, there was a vigorous discussion about one other agent, and that was labetalol, as opposed to separating alpha or beta blockers, however, and continuing the thiazide diuretic. Literature was reviewed, And if
Fine.
you've got essential hypertension
Fine.
on a thiazide, it doesn't seem to interfere, at least this is from the literature, in your volume status. If you put a pregnant woman on a diuretic while she's pregnant, that may be a different story. But that seemed to be okay. So we continued the hydrochlorothiazide, and amlodipine, Ronnie and Jan, was selected. And she was placed on 5 milligrams of amlodipine, told her to continue the birth control pills for 1 more month. Came on. That was probably art of medicine, because we didn't know how long the ACE inhibition, and it would obviously wear off over that month. And she came back. Her blood pressure was exactly the same level on 5 of amlodipine and 25 of hydrochlorothiazide. And we said, get going. And that's we're waiting. We're waiting for the news.
Yeah, I think labetalol is a good drug in pregnancy, actually.
Yeah, we chose not to use it.
Yeah,
but,
no problem.
I want to thank the audience very, very much for what a tremendous way to start, obviously, day 2 and our split sessions. Thank you very, very much. Congratulate yourselves. A hand for the audience on the discussion, but also for Ronnie and Jan as well. Thank you, everybody.